New large trial on heart disease prevention just dropped, and they looked at people who were at high risk of having a heart attack or a stroke, but had never had one before in their lives. Why were they at high risk? For example, some of the participants had a lot of plaque documented in their arteries. Others had diabetes, and they've had diabetes for a long time, like many years. So they were a bit of a ticking time bomb. They just hadn't had that first heart attack yet. And so this trial asked the question, can we help these people prevent that first heart attack? So they gave them a drug called evolocumab. The commercial name is Repatha. So this is a pharmacological trial, and this drug is an injection that you take once every couple weeks. Plaque in our arteries is caused by these tiny little particles that float around in our blood called lipoproteins. When there's too many of them, they can get lodged in the artery wall. And so what these drugs do is they cause our liver to pull more of those particles from circulation. There's fewer of them, less plaque buildup over time. Now, this evolocumab or Repatha belongs to a class of drugs called PCSK9 inhibitors. Some of you are probably familiar with that. If you're not, if you've never heard this before, don't worry. We're going to go into a little bit more of the details of how these drugs work. But basically, they've already been shown before to help for people who have already had a heart attack or a stroke to prevent more. So this is called secondary prevention, right? People who are very, very high risk. But what had never been done before with these drugs is to ask this broader question of the primary prevention. People who have never had a heart attack or a stroke in the first place, can we help prevent that first one? So that's what this trial set out to test. Now, most participants in the trial are already on some form of lipid-lowering medication. A lot of them are on statins, others are on ezetimibe. So different classes of drugs. And then they're getting this PCSK9 inhibitor, this evolocumab, on top of those medications they're already on. So they started out with 12,000 people, a little over 12,000. So it's a massive trial, and they split those people randomly, and they gave the drug, the evolocumab, to half of them. The other half get a placebo. Basically, it looks the same, is administered the same, but doesn't contain the drug. And the participants don't know which one they're getting, so it's a blinded trial. The drug was very effective at lowering lipids. It lowered LDL cholesterol by 55%, non-HDL cholesterol by 47%, and ApoB by 44%. After 4.6 years, so about 4.5 years of follow-up receiving the drug or the placebo, the folks in the drug group had fewer problems like heart attacks, strokes, or deaths from heart disease. So when you combine those three outcomes, the odds of the drug group suffering one of those was lower than the folks getting the placebo. Specifically, there were 443 of those events on the placebo group and 336 in the drug group. So basically, 1 in 4 roughly were avoided in the drug group. So that was their primary outcome, this combo of heart attack, strokes, death of heart disease. Then they also had some secondary outcomes that are more exploratory. So risk of heart attacks alone, 36% reduced on the drug. Heart disease deaths were reduced by 11%, but did not reach statistical significance. Cardiovascular deaths, so could be heart attacks, it could be strokes, anything cardiovascular, reduced by 21%, and all-cause mortality, so total death of any cause, estimated reduction of 20%. Another way to look at the numbers is what percentage of the total participants got an event. So for the main outcome, that combo of heart attacks, strokes, heart disease deaths, 8% of the controls suffered one of those, and 6.2% of the folks receiving the drug. So we call this the absolute risk. And you can see that the difference there is 1.8%. Now, the number one thing to understand when we talk about absolute risk is that absolute risk goes up with time. And in fact, you can see in the graph of their data, the number of events keeps rising in both groups, and the folks receiving the drug, basically the events are rising slower. 1 year into the trial, there's barely any difference. And then 2 years, 3 years, 4 years, 5 years, you can see the difference is slowly increasing. So the real benefit of controlling a risk factor is seen over the long run as the risk keeps going up and up. Another thing that you may have heard about is the number needed to treat, or NNT. It's basically another way to look at the numbers. It's very similar to the absolute risk that we just talked about. In fact, it uses the numbers from the absolute risk, just performs a calculation, but it's the exact same principle. So number needed to treat asks how many people do we need to give the drug to avoid an event, to avoid a heart attack or a stroke or a death from heart disease. And over those 5 years, the number needed to treat is about 55. So you need to treat 55 people to avoid one event. So the NNT is pretty high. And exactly as we said with the absolute risk, the NNT hinges on time of follow-up. So when you extend the time of follow-up, the NNT comes down pretty quick. So if over the lifetime we have, let's say, 50% of people who suffer an event like a heart attack or a stroke, which in a high-risk population might actually be an underestimate, but let's say 50%. And if the benefit of the drug is the same that we saw during the trial, preventing 1 in 4 events, then the NNT drops from 55 to 8. If 70% of people have an event over their entire lifetime, which some statistics suggest is likely in a high-risk population, then the NNT is 5.7. So this is the key realization. With a chronic disease, it doesn't kill you overnight, right? So it's about time of exposure. The risk is lower short-term, and it rises a lot with time. They also report the number of adverse effects, so side effects, and the total number was not significantly different between the two groups. Good to know, although I would have liked to see more detail. So the specific side effects on the drug versus the placebo, they don't report that. They just report the overall number and no significance between them. Some of the most common side effects with evolocumab with Repatha are cold-like symptoms, so runny nose, sore throat, also back pain in some people, and increases in blood sugar. That's seen in some people as well. Okay, let's talk about funding for a second. This trial is funded by the pharmaceutical company Amgen that produces the drug. These massive pharmaceutical trials always or almost always are, especially when they're the first one to test in a new context, like breaking ground like this. And that's because of the cost. In a perfect world, the government or the NIH or something like that would fund these large pharma trials. I would love to see that. If anything, we're seeing things going the opposite direction. Funding for research is being slashed. So we're nowhere near that reality. So how do we know if we can trust these results, since it's funded by the company that benefits from selling the drug? I just want to minimize my risk. I just want to be healthy, the same for my loved ones and my family and everybody out there. So how do we make a conscious, rational decision here? My approach, I look for consistency. I want to see the same findings reproduced over and over. And specifically with this category of drugs, the PCSK9 inhibitors, we now have 3 large trials. They all show benefits, reduction in things like heart attacks. So that increases my confidence. The other interesting step that we have in confirmation is genetics. And it's actually a fascinating story because PCSK9 inhibitors, they act on this protein called PCSK9, and PCSK9 was discovered through genetic studies. So they had these families that for mysterious reasons didn't get heart disease. They didn't get heart attacks or strokes. They were dying later. It was a mystery. What's going on? They had lower cholesterol and ApoB and these things and these lipoproteins. And so researchers investigated, discovered these mutations in the PCSK9 gene and discovered that these people were genetically protected from heart disease. And then what the pharmaceutical companies did is they tried to work backwards from that genetic understanding. They asked, okay, can we develop a drug that does the same thing that this mutation is doing in these families? Can we give this benefit to people who didn't win the genetic lottery, right, through technology? And so these PCSK9 inhibitors were developed, this technology. It's actually not a pill that you take. It's called a monoclonal antibody. So it has to be injected. And it basically turned out that people receiving the drug had a lower risk of having an event, like a heart attack or a stroke or dying of heart disease and stuff like that. So it's a really interesting story that starts with the genetics and then works backwards to the pharmacology. Now, if we look at these curves, the difference between the two groups is obvious, but it's also obvious that there's plenty of risk still left in the folks receiving the drug. Why? Why isn't this smashing that risk to zero? So one thing is heart disease has multiple risk factors. This drug reduces ApoB, these lipoproteins that are a major risk factor, but it doesn't reduce everything else. It doesn't reduce people's blood pressure. A lot of these folks had diabetes. PCSK9 inhibitors are not going to solve that. If you address all the risk factors, if you optimize everything, then it's a completely different story in terms of the magnitude of the benefit. But also, if we think about it, the intervention isn't even addressing the one risk factor. It's nudging it down. So these folks, their mean age was 66 by the time the trial started. These are middle-aged people with a lifetime of exposure, and now at this late age, we're reducing that exposure for 5 years only. This is why the effects are relatively modest, although you have a reduction in heart attacks of 36%, a reduction in mortality of 20%. It's pretty spectacular, but why isn't it larger? Why isn't it slamming it to zero? Because you're not really addressing the risk factor, you're tweaking it. If we really want to bring down risk to zero or near zero, or really slam it down, we want to address all the major risk factors, not just one. And we want to do it as early as possible in life, right? Avoid that prolonged exposure. Then we're talking some real treasure. And in fact, we know from genetic studies that those people who have the genetic benefit, who avoid exposure throughout life, the benefit is about 2 to 3 times larger than the benefit seen in these trials that are just 5 years late in life. So it all kind of makes sense. One other thing to bear in mind is that these drugs, these PCSK9 inhibitors, they lower LDL cholesterol, they lower overall ApoB, but they also lower LPA, which is a subset of lipoproteins that we talked about previously. And that's a characteristic of PCSK9 inhibitors. Statins in general don't do that. But PCSK9 inhibitors can lower LPA, not massively, but by 15-20%. So it's possible that some of the benefit is coming from that effect. Although when they looked at this trial in context with all the other trials that use these other technologies to lower ApoB, it aligns almost perfectly. They all reduce cardiovascular risk of events in proportion to the reduction of LDL cholesterol. And LDL cholesterol is being used as a readout of the number of lipoproteins, of ApoB essentially. So it's possible that some of the benefit is coming from the LPA reduction, although it's unlikely that that's the bulk of it. It's probably coming from the reduction of ApoB particles in general. So what does all this mean? What's the takeaway here? This trial shows us that these drugs can help prevent heart attacks, strokes, and death from heart disease, even in individuals who haven't had a heart attack or a stroke previously, and that wasn't known before. That said, these folks still had pretty high risk, not as high as the previous populations that were tested with these drugs, but not a healthy population, so it's good to bear that in mind. Another characteristic of PCSK9 inhibitors is they're expensive because of that technology we talked about. It's not a pill, it's a monoclonal antibody that gets injected. So these drugs are very expensive. The importance of these trials and testing this in broader and broader groups of people is that individuals who until now didn't have an indication may now qualify and have their insurance cover the cost of these drugs. So talk to your doctor. This is brand new, just dropped last week. Talk to your doctors about these new developments and what it might mean for you.